Good afternoon. Welcome to BRCA Strong Live on Monday with Dr. Kristin Rojas. We are just waiting a couple minutes for everybody to join and we will get started. Again, thank you for joining today. I'm Tracy, the founder of BRCA Strong. We are going to discuss disparities against in our breast cancer community to seeing how we can continue to make a difference. As we've learned, there is a higher mortality rate for African American women, and we want to take a stop to this. So we look forward to sharing and educating our community to see how we can make a difference and continue to make such an impact in our world. The more education we have, the better off we are. As one thing that I do always say is knowledge is power. So let's take this knowledge today and share it with all of our friends and family. No matter if you have a predisposition, if you don't, if you're the first person diagnosed, we are here to continue to make this impact on a daily basis. So again, we're just waiting for Dr. Rojas to join us today and we will go ahead and get started. Thank you everybody for joining. It's so good to see all of you. And I'm honored today to share and to make sure that you guys check out our new website as we have just launched today, and we'll be sharing lots of new information with you as our programs will be changing for 2021 and more information to come. Just bear with us as Dr. Rojas is logging on, and we really look forward to this conversation today. And good afternoon to all of you again that have just joined. I'm Tracy, the founder of BRCA Strong. Thank you everybody. It's so good to see all of my amazing supporters and amazing physicians on this call. I'm so honored. Dr. Rojas, you're going to hit join now and it will send me a request. Just bear with us, guys. Hey, Hannah, amazing live call yesterday. It was so good to watch and see you and online and sharing your stories. It's so imperative, as all of us know, no matter what our journeys are, what we're going through, just to share your story really truly makes an impact. So thank you all again for sharing your stories and making sure that we're sharing what's going inside of us, as all of us are different and share our stories in different ways. If you're interested in doing a blog, if you're interested in doing a video, we would love to hear from you. Hey Aaliyah, good morning. Great to see you on. Hope you're feeling well. Hi Pink Fight, thank you so much for joining. We look forward to speaking with you and sharing, and spreading awareness again is so imperative, as everybody has a different journey, but sometimes just hearing other stories makes you feel like it's eliminating the feeling of isolation and you're not alone, because that's one thing that BRCA Strong really wants to make sure we do, is encourage women to know that they are not alone in their journey. Dr. Rojas, were you able to join? Give me 1 second, ladies. So Dr. Rojas, log out and log back in and you should be able to come in. Hi Myra, great to see you. So thankful for you joining. I know it's been a little busy in our own journeys, but I saw your post and I am so happy, and happy anniversary, and glad that there's no evidence of disease right now for you. Thank you again for sharing your information and your story, Green Ninja. So just bear with us a couple more minutes. Again, for those of you that don't know me, I'm Tracy, the founder of BRCA Strong. If you have not seen our new website today, please make sure that you go ahead and you go on and check out all of the new available resources that we have. I am definitely emphasizing breast reconstruction options and knowing what is available to you. So please check it out and make sure that you share with everyone that you know your breast reconstruction options, as we are not often given them. And I feel that it is an imperative piece of our journey that we all know our breast reconstruction options. So just make sure, if you haven't seen our site, please make sure you check it out and share it with your friends and family, because knowledge is power, like I was saying before. And just knowing what's going on in the community, and the women that are being affected are younger, and due to COVID-19, we're having breast cancer diagnosed at later phases. So just make sure you share your, not even if it's your story, but just make sure that you're sharing information, because breast cancer is 365 days a year. A lot of us kind of block that out and think, oh, well, it's October. No, breast cancer doesn't quarantine, and it's 365 days a year. So just make sure you stay tuned to all of the new information and things that we have coming at BRCA Strong. As we are just holding tight, waiting for Dr. Rojas, please bear with us. And it is great seeing everybody. Hi, Paola. Great to see you. I love seeing all these new faces coming on to hear from Dr. Rojas, as she has so many things to offer us in our community. And if you don't follow her, please make sure that you follow Dr. Kristin Rojas or Music Therapy. She has some amazing programs out there for women who are survivors, and knowing that these options are out there by different physicians. It's called Music Therapy, and she can elaborate on that just a little bit. But again, make sure you find her on Instagram. You can find her through our page. She is an absolute amazing asset to our community and continuously educating us. So I definitely look forward to having her on today. Hey, Mary, great to see you. You know, Hannah, it is very sad how our rates have gone up since our pandemic, and really the priority of care to what women are doing and thinking that they're exposing themselves during COVID. You know, basically our facilities right now, I feel, are safer now than they were before. So if you haven't gotten your mammogram, make sure you do, or your screenings, and make sure that you do your self-breast exams. Self-breast exams take a half hour once a month to make sure you know your body and can feel your changes. That is imperative to know, again, your own body. Make sure you feel, make sure you touch, make sure you do it in the shower, make sure you do it in different ways. If you guys can just bear with me for 1 second, Dr. Rojas is having a problem logging on. Dr. Rojas, let's see. What I'm going to do, ladies, is, hold on, bear with me for 1 minute. Dr. Rojas, I just sent you a message if you want to check it. And it should be asking you, do you want to join? Guys, just bear with me for a minute. We're having some technical difficulties. So Dr. Rojas, if you go to BRCA Strong's page, you will see that we're live, and then it'll send me a request once you ask. So go to our little butterfly on the top left, and you'll be able to see it, and then it'll connect you to live. Thanks, Hannah. So again, thank you, everybody. I'm Tracy, the founder of BRCA Strong. We will be getting started shortly with Dr. Rojas. So I'm not sure many of you know, but Black women are more likely, or 40% more likely, to get diagnosed with breast cancer and die. What can we do to make a difference? Does anybody know in the comments on what and why, what we can do to make a difference in this community? I would love some feedback, as again, Black women are 40% more likely to die of breast cancer. I definitely say that we need to make an impact on this and change what is going on in our community, whether it's clinical research, whether it's just your self-breast exams or getting your screens. We definitely need to emphasize this more in our community, whether it's low funding or can't afford it, or our families didn't talk about it. I know at BRCA Strong for this year, 2021, we will definitely be having some mammogram events coming up. And there will also be funding available for you. So if you are in Coconut Creek or South Florida and you need funding for a mammogram during our mammogram events, please make sure that you reach out to us, because we don't want this to be the reason that you are not screened. Dr. Rojas, I tried to send you a message to join, and it is saying that you need to download the updated version of Instagram. So ladies, just hold tight with us for a couple more minutes. Dr. Rojas, why don't you give me a call on my cell phone at 954-695-2863. Guys, just bear with me. We're gonna probably have to hold on just tight for a couple minutes as we're having some technical difficulties. So again, Dr. Rojas, just give me a call if you want, and I can walk you through what we need to do. Hi, Sassy Whistle. Good to see you. Hi, Kathy from My Faulty Genes. Great to see everybody. Thank you again for all your support. I'm super grateful and really want to thank everybody for coming on to these educational IG lives or Zoom calls, as this is how we continue to make a difference in our community and make the impact, is educating our community and sharing what is going on in different stats and different ethnicities, and just continuing to repeat that information on an ongoing basis to make sure that we can make a difference. So hold on tight, guys. Dr. Rojas is coming on. Hi, Dr. Rojas. Good to see you.
Hi, I'm so sorry. Can you hear me?
We can hear you perfect. No problem. Don't worry about it.
Oh my gosh, so embarrassing that it's like I didn't have you click the app update. So I apologize. I should have test drove this earlier today. I'm
It's
so
okay.
happy to see you. Thank you so much for having me.
Perfect. Thank you again for joining. What I'm going to do is I'm going to start with a short introduction of myself, and I will pass it over to Dr. Rojas. If you guys have questions, you can feel free to write them in the comments or feel free to send us a chat, and we'd be more than happy to answer you. So good afternoon, everybody. I'm Tracy Milgram, the founder of BRCA Strong, where we alleviate the financial and emotional burdens of women facing breast and ovarian cancer, regardless of predisposition to a genetic mutation, through advocacy, direct assistance, empowerment, and events. Our vision is to build a sisterhood within the sorority that nobody really wants to be a part of. So this is where we come as a safe zone together to educate and make sure that women have educational resources available at their fingertips, as I feel it is so imperative, going through a journey myself, to continue to make a difference. Today, we have Dr. Rojas, a breast surgical oncologist, who has so much to offer us in many different aspects. And again, if you guys didn't hear me, make sure that you follow Dr. Rojas on Instagram or her music therapy page, as those are two imperative pages that really help women going through a journey of a survivor, pervivor, or thriver. And today with Dr. Rojas, we're going to talk about Black women are 40% more likely to die of breast cancer. Why and what can we do? So Dr. Rojas, if you don't mind just to take a quick minute to introduce yourself, let everybody know again how they can follow you, and then we could jump into our conversation.
Sure. Well, as you said, nice introduction. My name's Dr. Kristin Rojas. I am a breast cancer surgeon, but I started my career in women's health. And so while the majority of my practice is taking care of women with breast cancer, with benign or malignant breast disease from a surgical standpoint, I also did have developed this sexual health after cancer program because I saw how prevalent sexual health issues were after treatment, and that we weren't always doing a great job addressing those. And so my Instagram is Kristin Rojas MD, obviously, but I did start sexual health after cancer Instagram specifically to address a lot of those issues for patients that can't see me in person and maybe anywhere. And so that is music_sex after cancer. And I'm so happy to be here with you today, technical difficulties of mine and all. And I think this topic is really, I'm so thankful that you suggested talking about this, because it has been something that's on my mind. It's on everyone's mind. You know, the events of last year after George Floyd's death and Black Lives Matter have really brought to the forefront the disparities in not only how we deliver care, but also the outcomes, and specifically and that's so becoming so not relevant, but it's so obvious in the realm of breast cancer. And we have these statistics like we had talked about, but I think it's important to think about it in the context of all that it's a very, very complicated problem, and there's multiple avenues that you can come at this, but I'm happy to talk about some of those. And then I came up like thinking of this, what our listeners could do about it. And so we can go through that as well. But it was also a good exercise for me to prepare for this because I learned a lot as well.
Perfect. Well, thank you so much for coming on and dedicating your time to helping us make a difference. I'd like to open up with the first question is, what are the reasons for the disparities in breast cancer survival between Black and white women?
Yeah, I think you can put kind of under three different headings. Number one is socioeconomic issues. And this is really complicated because it involves not only access to care, but it involves kind of some newer aspects of this that we haven't thought about before. Let me explain what I mean. So Black women and Hispanic women are more likely to be uninsured. And so it's not just a problem of being also a problem of access. So like they're also more likely to be burdened by things like transportation to their visits. And we know that breast cancer care is a multi-step process and involves a lot of visits, not only through the diagnostic process, but after treatment. And so, one of my colleagues here, Dr. Neha Goyal, actually here at University of Miami, is looking at how it's not, even when you hold some demographics consistent, it really does even matter. They're able to show that if you come from a certain neighborhood, you're more likely to have a worse cancer outcome. And we don't really know, we have some ideas as to why. Number one is, there are more toxins in the environment. Number two is access. So those neighborhoods are less likely to have great transportation or have a big hospital that's close by. Food, the food deserts, they're less likely to have internet access. Really important. There's this thing called redlining where internet providers are actually not giving as good of internet to some neighborhoods, and so it's an information problem. But it actually turns out it matters where you live, and some other elements of that might be that that the chronic stress of living in a resource poor situation where you don't have access to a lot of these basic needs may also in the end be affecting how aggressive tumor breast cancers are. And so there's a socioeconomic issue, under that umbrella, as well as the systemic racism that myself, I'm learning more about every day. I'm obviously not perfect, and it probably at some point have been part, haven't been part of the solution. But I think the first step is having these uncomfortable conversations, and it's true. The resources that are allocated to certain hospitals are completely different than others, and how insurance covers women from different backgrounds is also different. And then the two other aspects of this that we can talk more about are a biology perspective, like how aggressive are the breast cancers that Black women develop, and they tend to be more aggressive. They tend to be triple negative breast cancers, which are more likely to need chemotherapy and have more of a complicated treatment course. And even outside of just triple negative breast cancers, there's also genetic factors, which I know you know a lot about, not just one in BRCA2, but other similar mutations in other genes. And even outside of that, probably related to genes that we don't even know about yet. And there's actually some fascinating work happening by one of my our colleagues, a breast cancer surgeon in New York, who's looking, her name is Dr. Lisa Newman at Cornell, and she's actually looking at genetic ancestry, like specifically what part of the world did your ancestors come from, and how your genes may be different from someone who comes from a European ancestry, and how that affects tumor biology. That was answer for that. I'm sorry.
No, but it's interesting about like knowing your family history and the different genes and what's out there. And to me, maybe or I know that My Gene Council has a database, right, where you go in, and I'm not sure if you're familiar with it or not, where you go in and upload your genetic testing results. And from there, they send you follow-ups, they send you new clinical trials and stuff that are coming out. It's a phenomenal database by Ellen Matloff, who created it. But the question is like, what happens when you go for genetic testing and it comes back, right, unknown, unclassified? Like, what do you consider? And especially, for African American women, as we're speaking about this, what if that gene isn't developed yet and it's there? Any guidance on like what? I know obviously once you do genetic testing, but then following through with that genetic testing, and like just because you were not negative or inconclusive before, what does that mean, especially in our African American women and men?
Yeah, so that's a great question, and it comes up both like within the context of race and access and outside of that as well. And what you're talking about is something called a VUS, or variant of uncertain significance.
Uh-huh.
Yeah, so it's tough because now we don't just test for BRCA1 and BRCA2. We're testing, we have these big multi-gene panels that we may customize according to your specific risks, or we will send, if you're very young with breast cancer, we send large panels to look for all these different mutations. Some of them we have things that we can do for, and others we actually don't really know what helps yet. And so kind of the in-between of that and no mutations identified, because we're using these big panels, we're finding more and more of these VUSs, or variants of uncertain significance. When you actually listen to VUS, like uncertain significance, like nobody wants to have one of those. Like that doesn't sound very reassuring at all. But according to our guidelines, we're actually not supposed to act on those because the majority of them later on are downgraded to benign. There's a small risk of that VUS being upgraded to likely pathogenic, or pathogenic meaning it has been found to be a mutation that does increase the risk of breast, ovarian, or another cancer. So yeah. And the other crazy thing about this is that not all genetic testing companies communicate with each other, so they have their own data. Yeah, but there is a database called ClinVar, where these different VUSs are being put into this database, and as things get updated, that database is updated. So if you're someone who has a really scary family history and you have a VUS, I would ask your doctor to refer you to a genetic counselor as well, because they can also help with follow-up regarding it when the status of that changes. But just like anything else, if you are someone who moves a lot or doesn't check in with your doctor that much, or for all these other access reasons we talked about, you're much less likely to know about that. It is a very rare occurrence, but it does happen.
Perfect. What can African American women do to advocate themselves when faced with a diagnosis of breast cancer?
Yeah, so African American or Black women, okay, divide this into when they're faced. So after they're diagnosed, you've been diagnosed with breast cancer. Since becoming a breast cancer surgeon, I've always been so impressed how women become experts in their disease. They look everything up. They have a PhD, a personal history, and often give us, you got us more information than we could have ever read or from a textbook. But so for those women, I really want to empower women to advocate for themselves, but there are some specific things to ask. Number one, what type of breast cancer do you have? If you are negative breast cancer, your care, or HER2 positive breast cancer, your care may be a little bit more complex in that you may need chemotherapy before surgery. And in that case, taking you directly to surgery and skipping that point may end up meaning you have a worse outcome. And so and we have specific guidelines for this. And so it's really important that your provider is following the NCCN guidelines. And one of the ways you can know that without being an oncologist yourself is ask your doctor if they're part of a multidisciplinary tumor board. So tumor board, it's a terrible name, but this is but that's what it's like, a multidisciplinary conference, basically, where once a week or at a certain time period, all the surgeons, all the medical oncologists, all the radiation oncologists, social work, genetics, all of the people relevant to a patient's care meet. We review new diagnoses or complicated cases. And it's kind of like everyone else is holding your feet to the fire, per se. Like if you're doing something wacky with one patient, which doesn't happen. I mean, I've never been in a situation where that happens, but, you know, it's a good time for you to get information from your colleagues and for complicated cases, but it's also a little bit of checks and balances on making sure that every patient is getting the standard of care. And so making sure you're being treated or asking about whether your case is being presented at a multidisciplinary tumor board. Number two, patient navigators. They can be so helpful because it is really complicated getting you from surgery and then radiation plus or minus chemotherapy that's up to. So being in a place that has a patient navigator is also a huge deal. And then, you know, if those are for women that are already diagnosed, ask about clinical trials. And this is also complicated because, you know, there is a mistrust of the medical system and clinical trials based on race. And I'm, you know, a Hispanic woman, but I can't even begin to understand how complicated that is to to know that we really did so poorly, like our government did such, and I'm referencing like the Tuskegee trials and among other inequities that are really gross problems that happened in our history of clinical research. And so what I think one element of that is that not only is that Black women are underrepresented in our clinical trial results, and that's a huge crisis. We need the patient populations of studies to reflect our actual population. So if you're only studying white women of European descent, those results are not going to be applicable to Black and Hispanic or Asian American women. And so it is so important to have a diverse patient population when we're doing these clinical trials. And so ask your doctor if there are any that you qualify for, specifically triple negative breast cancer, because there are so many new agents that are only available on a trial right now. And it is like vaccines that we can give you. And being on a trial, it's a common misconception. Oh, I'll get no treatment. I'll be randomized where I get no treatment. And that's actually not how it works. Everyone gets the standard treatment arm. Usually everyone gets treatment and then one arm will get something extra. So just by participating in a clinical trial doesn't mean you'll get substandard care. It means you'll get standard care plus an intervention. Usually that's how they're designed. And so it's important that we know that everyone knows that.
I think you brought up a really good point on how we don't have clinical trials in African American women, and women go back, you know, on their stats and look at data and look at research, and we really don't have that. I don't know, maybe you could give one piece of advice to an African American woman on why they should participate in a clinical trial, why it helps us. You know, I think a lot of people here, like we talk about, right? Oh man, a clinical trial, I'm a guinea pig. No, we're really not guinea pigs. We're helping us to help other people. So different lines of medications, but maybe from a physician standpoint, if you could give me like some piece of advice on why, especially we need more African American data for our medications and our trials.
Yeah, it's a problem. It's important not only because we want to make sure our results are applicable to women, but also because, so for some trials where it's newer agents, so for the triple negative space, you know, this is rapidly evolving. There are these new medications called drug antibody conjugates that are or other like immunotherapies that insurance may not cover because they're not FDA approved yet. So these trials that have shown to be effective in like phase 2 trials aren't going to be covered, and you wouldn't have access to those, to the opportunity to have that otherwise. And so sometimes being on a clinical trial is the opportunity to get a medication that isn't like we're not experimenting on you per se, but that medication to even get to the point where you're able to be in that clinical trial has already passed like rigorous safety standards in the phase 1 and phase 2 clinical trials. So once it makes it to phase 3, we're we do collect a lot of data on safety and adverse events, and everyone knows about clinical trials now with COVID. But one is that you may have access to the newer therapies otherwise, and number two is that we want our results of these trials to benefit all women and not just one population of women or men. Along that, men should also be in our clinical trials because men get breast cancer.
100%.
Yeah.
The first question is what interventions can Black women utilize to decrease their risk of breast cancer? And then if you want to touch base on like all women, but again, I figured let's start with African American women as this is our topic for today, as we're closing out Black History Month, right?
Definitely. So, all right, there's something called modifiable risk factors. So some things you can't change, like your genetics, yet, but there are some things you can change. And there's actually from another investigator that I recently heard present at a symposium. Her name is Dr. Julie Palmer from Boston University. And she was explaining through their work, just joining groups, research groups, patients, putting all of these individual research groups together into one big consortium so that they can really look at the specific risk factors, even more important for Black and African American women or Hispanic women. And it's called the AMBER Consortium. But what they have found is actually fascinating. So we used to say, you should have a baby to decrease your risk of breast cancer. You should breastfeed to decrease your risk of breast cancer. You should have a baby. It's like, all of this also sounds like a little bit patriarchal in my opinion, but I won't get political here. But it turns out that some of those risk factors actually matter more for triple negative or estrogen receptor negative cancer. So like I said before, Black women are more likely to develop triple negative breast cancer instead of hormone receptor positive. And what's really important is, so we used to think that the more babies you had, the lower your risk of breast cancer. But that's only true for estrogen receptor positive breast cancer. So having more babies in this recent data has shown that it may be the opposite for estrogen receptor negative breast cancer, that your risk may be increased for estrogen receptor negative breast cancer in the years after having a baby. Furthermore, breastfeeding is so important because we always knew it was a little bit important, but it seems to be even more important for women to decrease the risk of estrogen receptor negative breast cancer. And this highlights another huge inequity in our healthcare system in that, I don't know how many of our listeners are moms, but they may or may not have been delivered their baby in a baby-friendly hospital, which is like where the hospital has all these initiatives to encourage breastfeeding. And baby-friendly hospitals are more likely to have less than 3% of their patient population be Black. Like African American or Black women are less likely to breastfeed, like across the board. And it has to do with education of the resources, because breastfeeding is hard. Breastfeeding is not easy for everyone. So it has to do with support. Probably also may even have to do something with the stigma attached to breastfeeding. I can't speak to that much, but I can imagine that may play a role. And so breastfeeding. So to modifiable risk factors, maintain a healthy weight, eat lots of fruits and vegetables, get exercise if you can, and breastfeed if you can, because breastfeeding significantly decreases your risk of an aggressive type of breast cancer. And so those are ways to decrease your risk, but there are other ways that we can think of increasing the likelihood that you'll be diagnosed early if you do unfortunately develop breast cancer.
How do you think we can decrease the mortality in African American and Black women? What do you think we can do to our community as our listeners are hearing? And it's going to be on our YouTube channel. So if anybody's listening now can share this, obviously let's continue to make a difference. But how do you think we can decrease this mortality?
Yeah, a big thing here is early diagnosis, because Black women are more likely to be diagnosed at a later stage and are more likely to be metastatic at diagnosis. And so screening is huge here. And I know that, mammograms are controversial. because, they're not as good at seeing through dense breast tissue, which is what young women have. And there's conflicting guidelines, like the American Cancer Society says you can offer mammograms at 40, but the USPSTF says 50, and then ACS says something, ACOG says 40, and it's confusing, the care providers too, when they should send their patients to go get a mammogram. But if you have any family members with breast cancer, or if you're about from a risk perspective, then advocate for a mammogram at 40. And if your breast tissue is too dense, most states will mandate that you get called back to have an ultrasound so that we can use the ultrasound machine to kind of see through that dense breast tissue. If you have a significant family history, make sure you ask the doctor about whether you call genetic testing. If you have a BRCA1 or 2 mutation, we would screen you differently. Even without that mutation, but just a really significant family history, we would add MRI and catch cancers when they're smaller. And so and then for women who aren't 40 yet, who wouldn't be able to have a mammogram covered in insurance, doing your breast exams. This is also confusing with regards to the guidelines. Like the American College of OBGYN said, oh, women shouldn't do self-exams, we should have breast awareness. But it's like, what is breast awareness if it's not self-exams? So, if you notice that you have nipple discharge, a new mass, there's something different about your skin, like it looks like an orange peel, or it's redder, or it feels thicker or more hard, you feel a lump under your arm, do not wait. Go to your doctor and ask to get the imaging you want, because I'm fortunate to be at an amazing institution with a lot of resources, but I see women that come from before they get to me. So during the process of diagnosis, who tell me that, I felt this lump, but because of COVID, or because of a copay, or because I couldn't get the prescription for the mammogram, there's some sort of delay before they get to me. And don't let that happen. So if you're concerned about something, do whatever you can to get seen by your doctor and to get the breast imaging that you need.
As we know, breast cancer does not quarantine. You brought up a very big point, and I would like to go back and touch base on this. Obviously some families and some different backgrounds don't talk about, breast cancer, don't talk about testicular cancer, any of these cancers, right? Or some just talk about, oh, well, somebody passed away at this age.
Yeah.
Maybe the genetic link isn't there, but for example, for me, right, my aunt died in her 40s of breast cancer. So automatically we screen 10 years before. Is that correct?
So to my knowledge, and I've looked at the guidelines a lot of different ways, there's not a specific number that we say,
Okay.
like cancer, for instance. We know we start colonoscopy a certain number of years early than the young person diagnosed. We don't have that written, to my knowledge, that I've seen written in stone in breast cancer guidelines. But we do use our judgment like clinicians in starting some women early. We don't want everyone younger than 40 getting a mammogram, because there is a tiny bit of radiation associated with mammograms, and starting early before your breasts are full are completely done developing, which, believe it or not, they're still developing until your 30s, or after you have a baby, or after you breastfeed. We try to avoid unnecessary mammograms in those patients. And so there aren't specific guidelines with when to begin mammograms. But if you think that you might fall into that category, talk to your doctor about genetic testing, because then we would do an MRI on you, which doesn't have radiation. Or talk about a screening ultrasound, which has less radiation and is actually better for seeing through dense as well. Did that answer your question? So to answer your question, there's not a guideline saying number of years, but if that's you, we do kind of tend to think that things happen earlier. So it's good as a patient that you recognize that.
Perfect. One of the ladies is asking, I was diagnosed with DCIS in my milk ducts. Couldn't breastfeeding play a factor? Do you think that may have been a factor?
Yeah. So I haven't seen any data looking specifically at DCIS and breastfeeding. We kind of because of the nature of how we collect data in these large databases, we kind of put all breast cancer under the same umbrella with regards to breastfeeding. And across the board, in situ or invasive breast cancer, it does appear breast risk. So I don't think that breastfeeding increases the risk of DCIS, although
Okay.
I can see why you would think that, because it's like, oh, calcium in the milk duct, also DCIS, but it's actually related to the abnormal growth of the cells in the ducts that cause the calcifications. And so I think if anything, breastfeeding increases the risk and not increase the risk. But great question.
Perfect. What types of enhanced screening measures are available for the women at increased risk of aggressive breast cancer, such as African American and Black women?
So the American actually just adjusted their guidelines to add that say women from Ashkenazi Jewish background should be assessed for breast cancer risk by age 30. But now they've added Black women to that group, and because as a healthcare as field, we're recognizing that it's not just an access problem, but it's also a biology problem, and so that these younger women are more likely to develop aggressive cancers, meaning that they progress quickly, and waiting until 40 means worse survival. And so we recommend that all women of these high-risk women by age 30 receive some sort of assessment of your risk. So your primary care doctor, your OB/GYN looks at your family history, about whether you've had biopsy before. Like, someone needs to look at all of the risk factors specific to you, that knows you best, and make a plan for you.
Perfect. As we're coming to close out, I'd like to end and maybe ask you this, what can we at BRCA Strong do to change the unequal survival rates among Black women with breast cancer? As we make an impact on everybody, and we're all really equal, I feel, and a lot of diversity, but, I would like to be able to help our women at BRCA Strong and our followers. What do you think something that maybe we could work on to change all of this in our community, or national? Is it advertising and stating more facts? Is it sharing different stories, as we feature women on our blog? Is it maybe hearing more from our physicians on really what we could do, when to get screened? Is there any advice that you can recommend of what we can do to make this change?
Yeah, a couple of things come to mind. One is continue this forum of education, because for women, as like a society, we're not taught about our bodies all the time. And, like you said, there's taboo associated with talking about breasts, and, knowledge is power, and like kind of keeping us from that knowledge has been, obviously very detrimental for a lot of different reasons. So number one is continuing all of this great education stuff, your material and initiatives you have, which is fabulous. You and other founders of other similar organizations. Number two is we have to partner. Like, patient advocates play such a huge role. We need them at our medical conferences. We need their opinions when we're designing clinical trials. We need to partner with them and leaders of different communities, trusted members of communities, because I can't just go into, in any neighborhood and be like, okay, this is what we're going to do. All of you guys need to come to this hospital and we're going to implement these changes. Like, we need to really understand what the problems are. Like, where are we failing patients, like from an access perspective, and what other, so the community leaders are really the ones who can be the link for us to really know what's happening in these underserved communities. And so partnering between healthcare providers and organizations like yours and patient advocates, I think, is huge, and it will only continue to benefit everyone.
Perfect. And if anybody has any questions, you guys can feel free to send them in. And I really want to thank you, Dr. Rojas, for coming on and taking the time to educate women in our community. As you and I have spoken in the past, this is my passion. It's just something that I really love to do, and want to make sure that we continue to do it. So again, thank you so much for coming on. And before we end, I just want to let everybody know, again, if you did not hear me in the beginning, please make sure to check out our new website, as we have relaunched today, and we'll have all the different breast reconstruction options, information on genetic testing and screening. And just so everybody knows, remember, you're not alone. We're here for you. And if there's anything out there that we can do to support you, please feel free to contact myself or go through BRCA Strong, and we'll be here to help you. So Dr. Rojas, thank you again, and we definitely look forward to having you back on in the future.
Thank you so much for having me. I feel honored and privileged to be able to speak with you, and hopefully some of our listeners were able to learn something and can also spread the word about the things that we talk about.
Definitely, everybody make sure that you spread the word. We will have this on our IG page at BRCA Strong, and it'll definitely be on your YouTube channel. So again, even if you just send it to one family member or one friend, just make them aware of what's going on and to know your body. And again, I want to end on self-breast exams do not take 5 minutes. Self-breast exams should take a half hour once a month. Know your body. Knowledge is power. Don't forget. Thank you, Dr. Rojas. Have a great day.
Thank you. Bye, everyone.